One of the main changes is that we will have biological diagnosis, and I think this is very important. This is happening in some other neurodegenerative diseases, such as Alzheimer's and Parkinson's as well.
I think MS is a rapidly changing field, and within 7 to 8 years, we have a wealth of evidence that accumulates that allows us to more rapidly diagnose people who have MS and also use some tools to prevent misdiagnosis.
The diagnosis criteria will be more easily and widely applicable in many places around the world.
It's really inspiring just because I think it shows that the field is willing to be forward-thinking and incorporate evidence that's accumulated to actually change the lives of people living with MS.
Hello, my name is Xavier Montalban. I am the head of the Department of Neurology at the University Hospital Vall d'Hebron in Barcelona and the director of the MS Center of Catalonia.
Hello, my name is Jiwon Oh, and I'm a neurologist and the director of the MS Center at St. Michael's Hospital at the University of Toronto in Canada.
And I'm Brett Drummond. You're listening to the ECTRMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. One of the biggest MS news stories recently has been the latest revisions to the McDonald criteria used for the diagnosis of multiple sclerosis. This represents an important time point as the field continues to advance in both knowledge and technology. It is critical that our diagnostic criteria reflects this. Excitingly, these new guidelines have now been published and we can discuss them at length. My guests in this episode, Xavier and Jiwon, were both instrumental in helping to construct these new guidelines, which we will be discussing today. Xavier and Jiwon, thank you for joining me.
Thank you.
Thank you. It's a pleasure to be here.
So I think an important place to start this episode, there's obviously been a lot of talk around these revised criteria. But perhaps to start with, it would be good from hearing from both of you, why was there a need for revisions to the McDonald criteria to be made?
So I think every 5 to 7, 8 years, we consider that we have enough evidence to review the criteria. And the revision of the criteria has a clear impact on a number of topics. For instance, the dialogue between patient and neurologist, an impact on treatment decisions, an impact on long-term prognosis at the end. So I think that's a need, and that will be happening probably for many years until we end the disease.
I mean, I think just to echo what Xavier said, I think MS is a rapidly changing field, and within 7 to 8 years, we have a wealth of evidence that accumulates that allows us to more rapidly diagnose people who have MS and also use some tools to prevent misdiagnosis. And so it was time that we revisited all of the evidence that's accumulated to make things better with respect to diagnosis, which obviously has a lot of treatment implications.
Excellent. As we're recording this, excitingly, the publication has come out with the new guidelines. We're in a position now to be able to talk through exactly what is in there. So from both of you, I guess, what are some of the key changes that have been made to these criteria?
So I think one of the main changes is that we will have a biological diagnosis, and I think this is very important. This is happening in some other neurodegenerative diseases, such as Alzheimer's and Parkinson's as well. And that will be the first time that patients with no symptoms at all, but with a very characteristic and typical MRI, and also some of them with abnormalities in the CSF, they will be considered having multiple sclerosis. This is one of the important changes. And also, perhaps I will ask you to say something about the novel MRI signals that we will be incorporating as well.
Well, I think this set of diagnostic criteria, it's really exciting, and it's kind of a profound moment in the field just because it's the first time that more novel MRI measures have been incorporated into the diagnostic criteria. Just because when you look at how the diagnostic criteria have evolved for decades, it's been based on clinical measures as well as the typical clinical MRI measures that we use in the clinic. But I think, for people who do a lot of imaging research, it's a major landmark just because enough evidence has accumulated that these relatively simple to use MRI measures, specifically the central vein sign and something called paramagnetic rim lesions, in certain situations will enable and facilitate the diagnosis of MS in people who we think biologically have MS, and this will again facilitate earlier treatment in appropriate people.
Okay, fantastic. Do you want to go into a little bit more detail in terms of exactly how those imaging measures will be incorporated? What are the things that people will be looking out for?
Sure. So just briefly to describe what the central vein sign and paramagnetic rim lesions are, when you use certain iron-sensitive sequences, and this means that around, with centers around the world, when they have the capability to do this, iron-sensitive sequences will now become part of routine, probably diagnostic MRI protocols for MS. But when you use appropriate iron-sensitive sequences, when you see white matter lesions in the brain, there's actually many reasons, including MS, why people may have white matter lesions. But if a white matter lesion formed around a central vein, these iron-sensitive sequences allow us to visualize within the white matter lesion a clear central vein. And the reason this is so significant in MS is that's one of the pathophysiologic hallmarks of MS lesions. They form around veins because lesions related to MS are related to perivenular inflammation and demyelination. So what does this mean? It means that if someone has a lot of white matter lesions and that most of them show central veins, the likelihood of a diagnosis of MS is very high in comparison to many other diseases that can cause white matter lesions. And so within the diagnostic criteria, you'll see how they're used. But basically, there's this select 6 criteria. That means that if when you use the appropriate iron-sensitive sequence, you can identify clearly 6 lesions that very clearly have a central vein, the diagnosis of MS is very likely, and there's specific kind of criteria that need to be met. And if you have fewer than 6 lesions, as long as you have more lesions that demonstrate this central vein than those that do not, then again, the diagnosis of MS is very likely. And with the paramagnetic rim lesions, so these are called PRLs or pearls. Again, when you use appropriate iron-sensitive sequences, around some lesions you can see this rim of iron. And the reason we care about that is because these are known as chronic active or smoldering lesions. And it turns out, again, amongst the many different diseases that cause white matter lesions, chronic active lesions are highly specific to MS. And so in certain situations, and again, there's diagnostic algorithms that you'll see in the paper, if you are able to show that somebody has a paramagnetic rim lesion, again, the likelihood of a diagnosis of MS is very high.
Fantastic. Very interesting. Are there changes to the criteria that we should be aware of?
Well, I think on one hand, the criteria, some of them will allow a biological diagnosis, as I said, and I think this is a very important step. On the other hand, a set of the new criteria will make that the diagnosis criteria will be more easily and widely applicable in many places around the world, because for instance, we are incorporating the optic nerve as a 5th topography, and we will be able to measure that abnormality not only by MRI, which maybe can be a little bit complicated in some countries, in some centers, but also by visual above potentials or OCT, which is easier. We are incorporating the kappa-free light change apart from oligogonal bands, and they are easier as well. And then we have a number of signs or signals or criteria increasing the specificity. As Jiwon mentioned, the CVS and the PRLs are some of them, but also increasing the number of criteria in patients who are older than 55, patients who have vascular risk factors. For instance, in kids, we will be asking for anti-MOG antibodies as well. So I think the criteria meet the 2 components of increasing sensitivity, but also maintaining the specificity, or even increasing the specificity.
That's one of the things that we know around diagnosis that's been made very clear with all of the data that we've sort of established over the past few years is earlier diagnosis, getting onto highly effective therapies earlier has a big impact on long-term outcomes for people living with MS. Be interested in both of you commenting on the new criteria that have now been published and your thoughts on will there be anything around this that will help aid earlier diagnosis?
Absolutely.
Yeah.
I think, as Xavier highlighted, even in people who do not have kind of the typical clinical symptoms of MS, if these people meet, some of the criteria that we've talked about, we all know that these individuals biologically do have MS. Mm-hmm. And, this is an entity called radiologically isolated syndrome, or RIS. And it's in people like this where we know that biologically they have the same disease processes that are underlying MS, and a high proportion of people with RIS over time have a high likelihood of developing MS. So these are the types of situations that will facilitate an earlier diagnosis of MS, therefore facilitating the early initiation of treatment.
Absolutely agree. Perhaps we may say that the diagnostic criteria are not treatment guidelines, and I think we should distinguish the two of them, but there is a clear implication. And as Jiwon mentioned, it's very clear over time that when we are using new criteria, we had 4 revisions up to now, 2001, 5, 10, and 17, and this will be the 24, the 5th revision in 2024. The time between the first symptom and the diagnosis and the time between the first symptom and the treatment onset has decreased quite a lot. And as a consequence of this, the long-term prognosis has improved very much indeed. So I think this is one of the objectives, of course, of the new diagnostic criteria as well.
Fantastic. And I guess another area around that being misdiagnosis. Some comments around that, both in terms of, I guess, not missing people living with multiple sclerosis, but also not diagnosing people with MS that may have another rare neurological condition.
I think with diagnostic criteria, it's always tricky because you obviously want to increase the sensitivity and diagnose people with MS who biologically have MS, but then of course you want to prevent misdiagnosis. And so in terms of diagnostic terms, this means ensuring that the diagnostic criteria have high specificity. And again, I think this is one of the really unique aspects of this set of diagnostic criteria, bringing in some of these measures, including the central vein sign and paramagnetic rim lesions. And, the great strength of these measures are their very high specificity for MS, as well as sensitivity for MS. But I think building in these mechanisms to ensure that while we want to obviously increase the sensitivity, ensuring that we have ways to prevent misdiagnosis and maintain high specificity is really key. And I think, again, by bringing in some of these novel imaging measures, this is what we've been able to do with this set of diagnostic criteria.
Completely agree. As always, of course, perhaps a couple of comments. One is that with this revision, the diagnosis of MS requires to have an abnormal MRI. This never happened before. You were able to make a clinical diagnosis, a diagnosis based just on clinical grounds. And I think in 2024, this is not possible at all. Of course, we have a plan also to disseminate the knowledge, to disseminate the criteria among general neurologists, among patients as well, etc. And I think this is important. Of course, you need to know neurology, right, to apply the diagnosis criteria correctly.
I mean, you touch on an interesting point there that I'm keen to get both of your thoughts on as well around what would your messaging be now to neurologists, MS specialists around the world about adopting these criteria?
I think the criteria, they don't look easy, right? They don't look easy, I have to say. But then when you read them carefully, you realize that they are very easy and very easily applicable. So at the end, in the future, it will be easier to make the diagnosis of multiple sclerosis in most cases. And as Jiwon mentioned, we will be able to diagnose MS in few patients who otherwise will not be fulfilling the criteria. So read the criteria easily and don't worry, they will not make mistakes at all. I don't know, perhaps you can explain this better.
I mean, I think with any sort of diagnostic criteria, Xavier said this earlier, but it needs to be done by an experienced and trained neurologist. And I think some of the mechanisms that have now been built into the diagnostic criteria facilitates the diagnosis, but again has these, fail-safe mechanisms to hopefully, prevent misdiagnosis. And so I would say to the general neurology community, carefully apply the diagnostic criteria, and they're pretty easy to use. But when in doubt, use some of these built-in mechanisms that we have in the new versions of the diagnostic criteria that allow us to ensure specificity and make sure we prevent misdiagnosis. And so, when in doubt, just make sure you follow the diagnostic criteria and also get the opinions of other people, and then use some of these mechanisms that we have.
Lastly, now that we're sort of at the end stage of this and the guidelines are out, as two people who were instrumental in being a part of this process, we're talking about this as this has been an easy change. This has obviously been a lot of hard work and meetings and discussions that have gone into that. How do you both feel now that this has happened? It's obviously a landmark moment. And anything that you want to say around the other people who also participated in this process and helped make these changes?
Well, perhaps I can share with you that the meeting we had in Barcelona, and Jiwon was a fundamental part of that meeting, was very special, I would say. So people felt that we were doing a great job, and we were modifying the knowledge of multiple sclerosis quite a lot, and with a number of positive consequences. So I think we enjoyed the process. Was a carefully planned meeting with a clear methodology. That was the first time ever. We were 55 experts in multiple sclerosis from different areas of knowledge, and the female-male ratio was quite similar. That was the first time again. So I think could be as an example for future revisions that Jiwon will be leading.
I think there was a huge amount of work that went into preparing for the meeting. Xavier and his team really put in kind of, actually almost 2 years of work leading into this meeting. So I think it was really dense, but we covered a lot of ground. There was a very clear process. And as Xavier said, I think there was very good representation from, different, say, scientific specialties and global representation and gender representation too. So overall, a really informative meeting. It was exhausting, but I think we came out of it having moved the field forward. And, for me personally, seeing some of these novel imaging measures being incorporated for the first time, it makes me really optimistic about the field, because the fact that, this group of experts from around the world is willing to embrace how quickly the science in MS is changing, and that actually it makes a clear, tangible change in kind of one of the most basic clinical principles, diagnosis. It's really inspiring, just because I think it shows that the field is willing to be forward-thinking and incorporate evidence that's accumulated to actually change the lives of people living with MS. So overall, just really positive. And it was a lot of work. And we have Xavier to thank for all of the blood, sweat, and tears that for years, he's put into it. But it's, I think, a really, really positive change. And I'm excited that this has taken place.
Well, Xavier, Jiwon, thank you both for your hard work in terms of getting these new diagnostic criteria out, and the hard work of the rest of the team that was involved in this. And thank you both for sharing this with us today on the podcast. I'm sure it's going to be met with a lot of excitement.
Thank you very much for inviting us.
Thank you very much.
And thank you all for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MStranslate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRMS podcast is produced and hosted in collaboration with two key partners, MStranslate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2024-25 ECTRMS podcast series is supported by educational grants from Alexian AstraZeneca Rare Disease and Novartis. Educational grant providers have no input in the podcast content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook and YouTube.